live outside London. Welcome to the last workshop of the UK Regulatory Science and Innovation Network in Pharmacogenomics. We started this journey 6 months ago, and this is called the discovery phase. And the next phase is the implementation phase. And what we're trying to do with this workshop is really to see how we can move from the discovery to the implementation phase. So, okay, so if you look at regulatory science, which is the kind of area that we're working on with this network, and this is the FDA definition of the science of developing new tools, standards, approaches to assess the safety, efficacy, quality, and performance of all regulated products. So it's very broad, and clearly here what we're looking at are medicines as well as the diagnostics associated with that in terms of regulation, and trying to look at the whole ecosystem, which you will see is quite complex, to see how we can actually move that forward. And so what we've been doing is really working towards this implementation phase where we can apply for a Centre for Excellence in Regulatory Science and Innovation. And we want that to be very distributed across the country, four-nation approach, very collaborative, to see how we can actually develop those pathways, work with the regulators, and see how we can reduce their workload, but also try to make things as innovative as possible and move things forward for the UK for various reasons, which I'll come back to later on. So what the Innovate UK guideline says, that CERCs can undertake research to inform policy and respond to the needs of regulators. And there are many different issues we've identified in that over the last 6 months, and Cinzia will take you through that. We need to be able to train to upskill regulatory staff, but actually we need to be able to improve skills in other people, in other stakeholders as well, which may be industry, maybe the sort of healthcare community, and we need to be able to upskill the skills in here, which will be important in terms of implementation. Also provide expert support to regulators with complex assessments, and clearly this will help with that. And research-based solution for UK businesses to address not only our own regulatory needs, but also those of outside the UK as well, because we all operate hopefully, eventually, in a harmonized regulatory system worldwide, global system, but you do need to be able to move from here to the EU to the US, etc., and so on from industry perspectives. And there are other aspects which are really important. And this list is not exhaustive in the Innovate UK guidance. And so there may be other aspects we need to discuss today, and you will see that we will be focusing on some of those today. So when we put in the bid for the discovery phase, we identified 4 challenge areas. One was to including pharmacogenomic information in drug labels and developing guidelines. Second was embedding pharmacogenomic information with electronic health record systems and creating intelligent decision support systems. And we had a workshop on that. Then about diagnostic tests and regulation of diagnostic tests. And this is an area which is changing quite a bit and continues to change. So we need to be able to really focus in on that. And the third aspect was about health economics, cost effectiveness, and so on, which is important. And the aim of what we're doing is to develop proportionate, forward-looking, inclusive, and patient-focused, really pathways that enhance innovation and ultimately improve patient outcomes. So I think we have developed a collaborative network. Thank you very much for attending today. And we want to continue in that vein to be very collaborative and have this distributed network, which allows us to be able to develop that distributed center. Today's workshop is really to consolidate those learnings and get input into the implementation phase. It's got to be competition. Doesn't mean that we'll get it. I don't know how many networks there are, but there's only going to be 6 networks that are going to be funded. So there will be competition here. And the important thing is that there's an awful lot of work that's going on in the UK at the moment on pharmacogenomics with the Network of Excellence on implementation. There's work going on in Northern Ireland, in Scotland, and in Wales. And we do not want to compete with that. What we have to do is complementary, has to be something that helps all the other efforts which are going on. So that's the purpose of developing something, and the focus has got to be on regulatory pathways. It's not going to be focused on how do we do implementation. It's going to be focusing on regulatory pathways, so they aid implementation. So there's a subtle difference in terms of what we're trying to do with this network compared to what's going on with implementation and so on. So obviously we've got a new government, and they have their priorities, and it's important what we look at in terms of future grant applications, not here but everywhere else. Is that we need to be able to focus in on the government's priorities. If you look at the manifesto and the attention that's been brought forward since they won the election, clearly growth remains important, and not only growth within the domestic industry, but also attracting investment into the UK, attracting new industry in the UK. Innovation is always going to be important, and how do we actually not only innovate, but actually then get that diffused into the NHS. And that is often a major hurdle in terms of diffusion. Prevention is a big focus. Prevention, everybody talks about prevention, but nobody really does prevention. People talk about prevention in terms of the healthy lifestyle and so on, but maybe there are other aspects of prevention as well in terms of diagnostic tests, new pharmaceuticals which may be coming through. I think that in a few years, we'll all be on a statin, a GLP-1 agonist, and SGLT2 inhibitors, so that we can live forever. But that's where we're going towards, actually, in terms of what's going on. Maybe upskilling the workforce is always going to be important. Upskilling the workforce in all areas in the complicated ecosystem we operate in. And then there is a shift from secondary to primary care. The Secretary of State for Health has made comments that there's too much money going into hospitals. We need much more money in primary care. And clearly there's going to be a shift there. And that is this is consistent with prevention. And really, I always say that the National Health Service is not the National Health Service, it's the National Sickness Service. And what we need to do is to move to the National Health Service that we want. And all of that is intended to improve the outcomes for our population. And that is critical. And so whatever we do here in terms of innovation has to have that patient and public focus in mind in terms of whether we're going to succeed or not. So that's a kind of introduction. You will see that we've got a few talks, and that just covers some of the areas that we couldn't actually cover during the other 4 workshops. And then Cinzia is going to take you through the key points from the previous workshops, and then we've got some breakout groups in terms of areas we've defined for going forward for the implementation phase. We can't cover everything. Pharmacogenomics is very broad, and we covered a lot of different areas, but there's no way we can cover everything. So we've had to focus in on certain areas, and we can have a discussion whether these are the right areas later on. And we will have that as the breakout groups, and I've asked several individuals to be able to lead those breakout groups. Thank you very much for agreeing to that. It's usually people hate to receive an email from me because I'm usually asking them to do something. I apologize for that. And then we'll get some reporting from breakout groups, and then we can finish off by 4 o'clock. And last 2 times I've been in London, I've been stuck on a train because it's broken down. So I'm hoping it doesn't happen today. So you need to get away by 4 o'clock. Okay, so I'm going to go into the next talk. And thank you, Joseph from MHRA. And Joseph is going to tell us about adoption implications of IVDR. Thank you.
Excellent. So before I start the presentation, I want to ask the question, have you ever asked yourself, why do we have device regulations? Probably thinking in your head right now, why? Why do they exist? You're probably thinking all of these acronyms and words that are on the screen right now, safeguarding well-being or ensuring efficacy or sustained reliability of these devices. Yeah, those are right. Those are absolutely spot on things to think about. Have you ever thought about these next three? Looking at harmonized standards, maintenance of supply within our National Health Service, and more importantly, thinking about fostering innovation. This is really what regulations are really about. And my name is Joseph Burt. I'm the head of diagnostics and general medical devices within the MHRA. And I am responsible for a lot of the regulations that are coming down the line for medical devices and diagnostics. I'd like to just talk through a bit more some of that. So today I'm just going to speak specifically about the adoption and implications of in vitro diagnostics regulations in a genomic testing context, given that this is more a pharmacogenomics discussion today. So first and foremost is a bit of a health check warning I'd like to share with everybody. This is for your information for this session. It's not to be used beyond this session. And one of the things I'd like to just ask is if you could please refer to the MHRA webpage. It's gov.uk/MHRA. It's actually in the middle bullet point that you can see on the screen. And please look at all of the guidance and regulations and different publications that we have on that page. Most importantly, you come to the landing page of the MHRA, and the first thing you see is alerts, recalls and safety information related to medicines and medical devices, along with the yellow card system that I think everyone's familiar with, and other regulatory information such as the medical device regulations and safety. There's a lot of content on these pages, but if you literally just go to gov.uk/MHRA, you can get to pretty much most of the content that I'm going to speak about today. If you want to talk to us, you can always contact MHRA at the contact details at the bottom of the screen. It's info@mhra.gov.uk, and you can also phone us between 9 to 5, Monday to Friday. All right, so let's talk about regulations a little bit. And I'm going to probably be a little technical for the next few minutes here. So we have 3 tiers of legislation in the United Kingdom related to medical devices specifically. And it's all published online. You can read that for yourself. You have wonderful reading time for going to sleep at night. You go to legislation.gov.uk, and the first thing you should try and look for is a primary legislation called the Medicines and Medical Device Act 2021. And in that talks about veterinary medicine, talks about patient commissioner, but specifically for medical devices, we want to look at parts 4, 5, and 6. So then that's the act of parliament that allows us to make laws and regulations. So these are then secondary legislation that we have. Secondary legislation is the enacting of that act through regulations. And specifically, there are 2 regulations that are specific to medical devices and specifically in vitro diagnostic devices. The first one is the Medical Device Regulation 2002, and that applies to Great Britain. And I'll explain all of this in a second. It's a little technical. The second one is the Medical Devices Windsor Framework Regulation 2021. That applies to Northern Ireland specifically. I'll explain in a second why that is. And there's certain provisions there that we've enacted recently, just this past February, to talk a little bit more about some of the requirements we expect to see in Northern Ireland. And then there's tertiary legislation, and tertiary legislation helps support secondary legislation. We've got certain retained EU laws that are still in our legislation today. These ones down here as examples: electronic instructions for use for medical devices, tissues for human origin, and the designation of approved bodies that do conformity of the device itself. There are others, but I'm not going to list them out on the screen. So just be mindful there are 3 tiers of legislation that we need to think about. The most important is the middle one of the lot. So it's the Medical Device Regulations 2002 for Great Britain, the Medical Devices Windsor Framework Regulations 2021 for Northern Ireland. You're thinking, how does this all apply? It applies like this. I know we live in a 4-nation world here in the United Kingdom, but we operate 2 regulations. Okay, so the first regulation that applies is the Medical Device Regulation 2002. It applies to Great Britain, the red circle, the red outlined countries, Scotland, England, Wales. Okay. The second part of the regulation applies to the in vitro diagnostics regulation 2017-746. That's an EU regulation. Now, that's what I'd like to talk about today. And that one specifically operates in Northern Ireland and the European Union. It does not apply into England, Scotland, and Wales. That's a very important distinction to make. There's two regulatory regimes that operate across the United Kingdom, and you have to kind of navigate which one to apply when you are operating across the UK. So then, talking about regulations, there are key elements of the in vitro diagnostics regulation that I'd like to maybe just talk about just now. And it's really focused around these three areas. The first area is around the widened scope of the in vitro diagnostics regulation in the European Union. It literally expands the definition of an IVD to what it is today. And it starts to bring regulatory oversight into some areas that may not have been diagnostic IVDs in the past. So you'll have your traditional diagnostics, your blood tests, your cholesterol tests. Those are your traditional tests. But of course, the world's evolved. And with that, there are now things like software and certain instruments, some novel technologies that operate within companion diagnostics with a medicine, for example. And of course, genomic and genetic testing. So all of these start to become part of the regulation that will have oversight of those types of tests. The second category is around increased scrutiny. And this really brings emphasis around clinical evidence and quality management, as well as post-market surveillance. And I'll talk about post-market surveillance shortly. But with all of this, manufacturers of devices, that is genomic tests, genetic tests, companion diagnostic tests, instruments, software, etc., we need to think about the safety, performance, and the benefits of their products before it is used. And the third category I'd like to talk about is the harmonization standard. So one of the things I talked about in the areas to consider about device regulations is around harmonized standards. And really, the aim of harmonized standards is to ensure that there's consistency to the level of safety and quality of diagnostic products, IVD devices, ultimately for the protection of public and patient health. Let me now just talk a little bit more about the categorization of diagnostic tests. So this has changed recently for the EU, and it's still evolving and it's a little confusing, but I'd like to share a little bit more about it. So it introduces a 4-tier classification system based on a letter code, A, B, C, and D. A is your lowest risk tier. D is your highest risk tier. And you can see that on the right-hand side of the diagram, where you can see class A at the bottom and then class D at the top. What it also means is genetic and genomic tests, companion diagnostic tests, and devices for self-testing are all in that upper tier of classification called C. It's not the highest classification, but it's a lower layer down. It's still high, because it's still very at the top end of that. But it means that we need to start thinking about genetic tests, genomic tests in this classification system. And it's going to be at that upper level. So the scope of the genetic and genomic tests within the regulations are now starting to broaden. And that broadness encapsulates genetic tests, which cover, of course, hereditary-based diseases, your pharmacogenomics, the topic of this CERSI, and of course, companion diagnostics. It also starts to think about the data that's been generated from bioinformatics. So software platforms, bioinformatics tools that are used in the analysis of the interpretation of the genomic data is also within the scope of the regulations. And of course, most importantly, is in the use of precision medicine. So the regulations aim to ensure that safety and reliability that I've just talked about of genomic tests for use in personalized and precision medicine diagnostics is encapsulated within the regulations. So these are three very important areas that we need to think about in this CRC for genomic testing. So I talked a little bit more about also the use of the devices. One of the things around the regulations that is in IVDR is the great emphasis of the use and surveillance of these tests. And that is really taken in three forms, two of which we do today, and one is new. So it's the introduction of the continuous surveillance of post-market use. So manufacturers of genomic tests, genetic tests, and other in vitro diagnostic tests must continually monitor the performance, the safety of their diagnostic devices when they are being used in the actual settings in which they're meant to be used for. If there are issues such as incidents and concerns around the IVD device, they need to be reported to the MHRA throughout the various vigilance systems that we have. Yellow card being an example of that. And of course, the new element that we want to also introduce is around the market surveillance. And that is around making the manufacturers take more of the approach of appropriate corrective actions, product recalls, design changes, looking at systematic ways of doing that, and of course, addressing those safety concerns when there is a safety concern in use of that device, when it's out there in use. On the left-hand side of this slide, I'd like to just share this really important diagram. This concept of emphasis of use and surveillance is encapsulated in something called the post-market surveillance. Post-market, meaning after it's being put onto the market and in use, surveillance, regular use and an analysis of what's happening on that device. There's a framework that sits around that, and there needs to be a system that talks a little bit more about post-market surveillance. Again, we won't talk about that today, but it's a really important fundamental part of the regulations. So, what are the regulatory implications? And again, I'd like to just categorize it into three simple groups. So these regulations I've just talked about, looking at the classification system, looking at the post-market surveillance, looking at quality and clinical evidence, brings into alignment the additional requirements to make sure that there is rigorous testing upfront, and there is a certification approach to in vitro diagnostic devices, including those for genetic and genomic testing. Second is around compliance adaptations. So pharmaceutical organizations, diagnostic organizations that manufacture these devices need to adapt, design, manufacture, and introduce post-market processes in a very meaningful way that's very systematic. And third, and most important, is around improved patient safety. The regulations really aim to enhance, and the operative word there is enhance, the safety and reliability of diagnostic tests that really ultimately benefit the patient, healthcare professionals, and of course the users that are going to benefit from the use of these diagnostic tests. So let's just talk about how do the regulations work in practice? So I've just talked about regulations and a very high level concept. Let's talk about it in a more granular way of understanding how it applies. So you may not know it, but I hope you do. We are living through a medical technologies revolution right now. Think of what all these wonderful things that we're seeing coming out for use as medical devices or diagnostic devices. It's just incredible. During the COVID pandemic, we saw new technologies emerge, which we hadn't seen before, into clinical practice as well. So there are things such as real-time long lead sequencing with the insights of the human genome. We can do that now. We can interpret the genetic data to detect diseases earlier. We can predict patient responses to treatments and develop treatment therapies for very specific people, individual patients. And now we're starting to witness pioneering sequencing platforms that are transforming the field of personalized medicine. And I just want to share this one technology on the right-hand side. Does anyone know what this technology is that I presented on the screen? Has anyone seen it or used it? Oxford Nanopore Maya. Yeah. It's a very interesting technology. It's now at the palm of your hand instead of being in a laboratory having to do all this wonderful sequencing. So we have portable sequencing and analysis being done next to the patient with real high quality output. So genomic sequencing and analysis is really now taken out of the laboratory next to the patient. This is what we call near patient testing. So with that, that technology I've just shown you, it's used in a medical context, medical purpose, has to comply with the regulations for genomic testing. So I talked about the three categories of the regulations: wider scope, increased scrutiny, and harmonized standards before. So how does that apply to that piece of technology? Well, genomic tests using these portable devices are within that scope of the IVDR. They're now in that broader scope that has to be part of that regulatory framework. And they are Class C new patient tests. That's that second tier from the top classification. And as such, they are required to go through what we call a conformity assessment by a body which is independent of the manufacturer. It's called an approved body in the United Kingdom. In the EU, it's called a notified body. Okay. So there is rigorous review, assessment, checking, analysis of that device prior to being launched onto the market. So there's that incorporation of all of that wonderful oversight that needs to happen. There's then increased scrutiny of that device. The device manufacturer, Oxford Nanopore, for example, needs to demonstrate clinical evidence of the actual test, that it works. Number one, it's effective. Number two, it's safe. Number three, it delivers benefits. And the Oxford Nanopore will need to monitor that device in continual use. That is, once it's actually in use, it will need to make sure it collects the data of usage, make sure that it's providing all of the vigilance around that, and then reporting any incidents to the MHRA should there be any. The third group around harmonized standards is that portable sequencing analyzers and devices really need to perform to that gold standard. We have a standard today. It's the laboratory-based standard, unfortunately. It sits in a lab. It's not next to the person. So we need to demonstrate, or Oxford Nanopore will need to demonstrate, that it performs to that gold standard that sits in the lab, but it operates safely and effectively, just as it does in the laboratory setting. So this is a classic example of how those regulations really do apply. So what it all really means, it offers personalized treatment. So this handheld device that you now see, that you can get your DNA from a person, that allows you to sequence next to them, gives them customized medical therapies based on their genetic profile. So it gives that effectiveness, that reducing adverse reactions. And of course, you have that rapid screening that is literally there. I think it's 4 hours. I can't remember the exact time frame, how long it takes to do a full sequence. I think it's within 4 to 5 hours. You're able to get all the genetic variants, all that influences the medicinal metabolism of that patient based on their genome. So it gives them guided, you allow them to have guided selection of what the right medications could be. Most importantly, it starts to bring in improved outcomes. So optimize medicine selection and dosing, and leading to really better treatment outcomes for the patients that are involved. So hopefully that gives a little bit of a flavor of how the regulations start to think about the importance of in vitro diagnostics regulations within the innovation and the use of innovative technologies. So there is personalized treatment, rapid genetic sequencing, and improved outcomes. And with that, I want to say thank you very much for listening. I'll pass back to Vinny.
You could take a couple.
Yeah, sure.
Any questions? Because you are running behind time, so maybe one or two. So what happens, Joseph, when you have a diagnostic, but then you also have an AI component in there as well? So there's two different devices that you actually have to regulate. How do this work?
Excellent question. Excellent question. So especially with data is now able to be passed through an AI algorithm, and then there's some outcome that will be produced through it. So there are two parts to it. There's the AI part, and then there's the diagnostic part. So I talked specifically today about the in vitro diagnostics regulation. There is a parallel regulation for the medical device regulation that also applies in Europe, and that's where AI is covered. It's very similar, actually, to the requirements of IVDR. They're almost like sisters and brothers of each other. Okay, but you'll need to apply both.
Please.
You talked about the need to show effectiveness, clinical effectiveness of these interventions. Will the MHRA be issuing guidance as to what kind of studies, what kind of designs would be needed to show that effectiveness in the way the EMA publishes guidance on particular disease areas, what trial design should be like?
Interesting question. Good question. The answer is we don't have that guidance presently, but we are trying to do this in a more global context. So you just don't do a study in the UK, you have global studies as well. So we are part of a group at an international forum called International Medical Devices Regulators Forum, IMDRF for short, where we're looking at this topic specifically, clinical evidence requirements in a harmonized way with other jurisdictions. And you can read the publications that we have online. There's actually one person I'd like to introduce who actually helps run that forum, and her name is Annie Truong, and she's actually just in the middle of she's got her hand up. So if you'd like to ask more questions of that area, please approach Annie.
Thank you.
Okay, Dan, last question.
Yeah, thanks for a nice presentation. Could you say something about how you think international recognition could impact where regulatory science might go? Where does the UK want to lead in regulation? Where is it more likely to accept regulators from other jurisdictions?
Dan, good question. So for medical devices, the MHRA recently published the policy intent for international recognition. And we're working through some policy areas just now around the details of that, what it means, how it applies, the piloting of that for medical devices. It's not like the international recognition procedure that we have for medicines, but for medical devices, please have a read of that statement intent. The key element out of that is that we would probably want to go down the path of recognizing certain jurisdictions' conformity assessments. We do today. The EU, for example, we recognize the CE mark today. But we maybe continue doing that. That's within our published policy intent. There are other jurisdictions in there as well.
Okay, great. Thank you.
Thanks very much. Thank you.
Okay, let's move on. So remember that in our previous workshops, I think it's workshop 2, we had something on electronic health records, but focused on primary care, where we had talks from EMIS and TPP, but we really didn't focus on secondary care. So great pleasure to welcome Catherine Procknow, who's going to talk about EPIC and so pharmacogenomics. So thank you. Sure. Yes.
About 6 years ago, I moved over to the genomics team, which I'm going to be talking to you about today. So first, I'd like to do a little bit of myth busting. So you may have heard that genomic data is far too complicated for an EHR system to handle. And that was true in the past. So genetic testing results were typically returned as a PDF report. Those look really nice. They're easy to understand and read through, but they're not useful downstream. And with the EPIC Genomics module, we've made a home for structured genomic data along with those result reports filed to patient records. So we've built out a variant data model that can actually hold those discrete computable results behind the scenes. PDF result report still comes in. We actually are always improving this variant data model based on feedback that we're getting from our customers so that we're able to support all of the different types of results that they receive. And I really do mean it. We make a lot of updates to this data model and it's ever evolving. So interoperability has always been very important to Epic. In fact, it's essential. There is absolutely no way that our customers could connect to all of the different systems they need to take care of their patients without scalable, safe, open standards. So we are strong supporters and co-developers of these standards. Some fun stats here on the slide. These are transactions that occur in just 1 year. We exchange over 1.1 billion patient records for patient, follow the patient wherever they receive care. 20 billion API calls and over 234 billion interface transactions. And it's actually standards-based exchange that powers our genomics functionality. So these are the different ways that structured genomic data is exchanged with our systems. Epic includes a LIMS system, so that's why you see orders and results going in and out of Epic. We have support for FHIR reading of genomic data out of Epic. And we're also building support for the GA4GH variant knowledge standards within our interpretation product that's under development. So when genomic information is computed, or is communicated in a structured, computable format, that's what makes it actionable. So variant results, they contain a lot of details that specialists need and understand, but most doctors don't know what to do with them. And that's why we built translational tools into the software that connect variants with knowledge about those variants to make sure those details turn into what really matters. So I'll give you some examples here. I think most folks agree that interruptive alerts or advisories at the time of ordering is a really good way to put pharmacogenomic results to work. So in our software, we can create advisories to automatically adjust dosing or even cancel an order and replace it with a medication that might be more appropriate for the patient based on their genomic profile. We can do a lot more with that same infrastructure, actually. So that same infrastructure can actually provide either active or passive advisories in the software to notify doctors when their patient might qualify for a clinical trial or a research study based on their genetic testing results and other clinical information. And we can help identify targeted treatment for cancer patients based on their biomarker. We can actually move decision support based on genetic test results even earlier in the ordering workflow, even before ordering happens. So here's an example where a default order is replaced with something that's more appropriate for the patient's pharmacogenomic profile. That dosing is automatically adjusted. We're alerting the doctor. We can also provide clinician-facing and patient-facing education. So here's an example of patient-facing education that's available in the patient portal, MyChart, based on this patient's pharmacogenomic result. And even when you're in a workflow where you're not reviewing a patient's genetic testing results, we want to make sure that genomic data is really easy to find. So we've built the ability to find genomic data within our search functionality. It's easy to navigate to when needed, and we maintain that full context of the order and the patient. We've also included support for genomic data in our reporting functionality. So here's an example of an out-of-the-box dashboard that we've created to help monitor genetic testing orders as they flow through and are completed. So it's easy to drill down, find bottlenecks, and figure out what's going on with different tests. And that support for reporting actually extends to the variants themselves. So this is an example of a really, really simple query in our data warehouse that's based on variants. This is actually real data from a newly implemented system where they've just started using the genomics module that just returns the number of patients who have had variants returned in these 10 genes. Very easy to combine these types of queries with other clinical data queries to drill down on the associated orders of the patients and make new discoveries. So over the last few years, we've had many groups go live with this functionality, and they're finding success and they're bragging about it. So let that speak for itself. And we found that there's an exponential increase actually in the number of structured variants that are being returned by labs as groups adopt this functionality. So over 4.3 million variants have been returned to an EPIC system. And again, all of that is made possible by standards-based exchange. In particular, the transactional exchange of orders and results through these HL7v2 interfaces. So, along with many other experts at EPIC, I've been reviewing the NHSE draft implementation guide for genomic data exchange. And the focus of that guide is really on the ordering side. It's not on the resulting side, and it doesn't include structured results. And that really is the key to powering all of the functionality that I just went through. None of that is possible without structure. I have also heard that there is interest here in centralizing the logic for decision support around pharmacogenomics. And to that end, I have a few approaches to suggest based on what's been successful in other implementation. So both of these approaches still require that HL7v2 is used to send structured data, structured results back to the ordering provider to power all of that functionality we were just talking about. But it's also possible with a CDS hooks-based FHIR application to centralize that decision support outside of EPIC. So this is just an example of how it works. So a CDS hooks approach is when the medication order is placed, we can fire out a message to the decision support application. The application can call back and gather whatever clinical data is necessary using FHIR, and then calculate what decision support to display and send that back. We can display that. Another approach that's been really successful is something that we're trying in the US right now. So we have a shared customer governance structure where our customers are coming together. They're saying we don't all want to have to build the same thing in each of our individual systems. And so we're working together to build that centrally in our foundation system at EPIC. It's something that's maintained by EPIC. And actually customers can subscribe to the foundation system for pharmacogenomic content and get updates or to take that build and as activity scores or genotype to phenotype mapping changes, we can actually proactively push out that build to customers who are interested. So that is what I have to share with you today. I am very much looking forward to helping you implement pharmacogenomics across the UK.
Really interesting. I have two quick questions. One is how frequently these underlying support tools are updated in terms of emerging evidence. And the second is around transferability into other systems. I'm assuming this is all based on CPIC and US prescribing guidance, which is different from other countries. So even aside from PGX, we have different prescribing guidance in the UK that would lead to different first-line therapies and then cascade, etc. So how do you envision interoperability across the sort of diverse prescribing ecosystems?
Yeah, I on the second point, I think that this model could be supported for the UK guidance the same way we're supporting it for CPIC in the United States. We would just build different decision support in our UK focused foundation system. Push it out. The decision support build itself can be updated regularly. Epic has quarterly releases. And so we, every quarter, make updates to things like our gene master file and our pharmacogenomics. We push that.
Thank you.
Hi, yeah, I was wondering, it's very interesting, the alerts that you're doing for doctors. I was wondering whether that makes it a device or not, but where do you extract the information from in order to support those alerts?
So the information that supports those alerts is actually what's filed to the patient's record.
No, when you talk about an interaction with the drug or something like that. So do you
the
take
build,
that
the logic itself.
from the product information for the drug, or do you look at the literature, or how do you extract that information?
Okay, understood. So each of Epic's customers actually owns their own system and is in control and ownership of their own build and the logic that they put into the system. We really make the pipes for that, make sure the logic can work, but it's configured at each individual site.
Just to your question.
Can I have one question from Alison asked you? So Epic is a platform that is configurable by the customer, and the customer can then do whatever logic it performs in that, including calculations potentially as well. But it's the customer that decides that.
Correct.
But decision support systems in the States don't require device approval, is that correct?
Sorry, Atul Chowdhury, I'm a physician here at working for Epic in the UK. In the UK, that decision support framework is regulated under MHRA regulations, was under European regulation beforehand. And to come to the question about the medicines, the customers buy a standardized drug formulary from a number of suppliers that are out there. Typically, most of the UK use the First Data Bank formulary, and that drives all of the decision support that they use for sort of standard things like drug allergy, drug food, drug lactation, drug pregnancy, and so on. So then there are elements related to that that are also can be augmented either by other knowledge related to genomics, or some of that may already be built in. For example, if it's known around, say, liver enzyme metabolism and so on, that's already baked into that formulary. So there are two sources of information they can use for that. In terms of the customers configuring the system, they can configure the system, and it delivers a vast amount of flexibility. All of our customers tend to use a standardized model for that, involving, so for example, simple things like Glasgow Coma scales and early warning scores, to the far more complicated models that are deterministic, although we are now starting to move towards a more probabilistic type of methodology. But again, those would be classed as more medical device regulations.
But the customer does that, not Epic. So the Epic will release models that we know that are based on published data, and customers can just adopt that. They go through a round of testing and validation in their own instance. If they have their own models, they can build those, or they typically, so for things that are very routing, so Glasgow Coma scale, those sorts of things are in our foundation system and are shared amongst all other customers. But if there's, so for example, I was having a conversation this week with the National Centre that wants to introduce a new maternity early warning score system. We've got a new algorithm. They're going to put that out with a professional lens to say, this is what we want you to implement. Our customers will configure that in their system, go through a round of testing and assurance, make that live for their clinicians to use.
So how would the medical devices approval work in the EU in this situation?
It's a medical device.
Yeah, it would have to be done by the customer or by the.
That's my question, actually.
So the scoring part is, so it partly depends on the nature of the scoring algorithm and how is it just simply adding up things or what have you, but it feeds into something that we call our regulated decision support framework, which is regulated as a medical device. So it falls under those frameworks that we already have approval for.
Okay, well, thanks very much. I'm sure people want to ask you questions later.
Sure, I'll be here.
Yeah. Okay. Next talk is by Scott Watson, Future of Digital Interoperability.
Good morning, everyone. Just very quickly, just a little bit of an introduction. My name is Scott Watson. I'm a solution architect for NHS England. Part of the week, outside of the week, I'm the digital lead for Northwest GMSA and the solution architect RX trial in the Northwest. I've only got 10 slides today, so it's not death by PowerPoint. I appreciate you've probably been through presentations, needing to get some caffeine in. But first, what I want to do today really is I want to just sort of briefly outline the difference between interoperability and integration, because I find it's really important that people sort of have the same sort of understanding, because connecting different computer systems together can be quite complex, and how we use the language can be quite sort of different. Then I want to cover a little bit about the unified genomic record, how that's a key enabler in our strategy from an NHS England perspective, be able to support the sharing of genomic results, and more importantly, the models on how we want to mainstream pharmacogenomics across England. And then I'll be happy to take some questions at the end, if that's okay. So just moving on. So really, the main thing that I want to sort of like focus on once again is distinguishing that difference between integration patterns and interoperability patterns. So integration, here's sort of like two main examples, and the presentation before me just sort of like highlighted one, which was like orders and results going by HL7 in and out of the system. But the first one is commonly used in the NHS, which is really taking a copy of that data and transmitting it to another system. So you're taking a result from the LIMS system and you're taking a copy of that, then putting it into either an order management system or into an EPR. Then potentially, if you're putting this into a shared care record system at an ICS level, you're taking another copy of that and pushing it up into an ICS. So you're never really working off the original version of that. You're always taking a particular copy as you sort of bounce it around the system. And that's the most common sort of patterns that we have, especially for pathology, diagnostics, radiology, etc. In genomics, we're predominantly paper-based. We're quite sort of behind in that space. And one of the things that we want to try and address is basically moving through interoperability with structured data, etc. The second example is really focused on integration, where you have a view of the data. So if you're in A&E and a consultant wants to access something about medications, etc., they would click through to a view of summary care record, which is actually hosted in the National Care Record Service. So it's like a web page that's displayed in context, and it might take some information across, like the patient information across, the hospital that's requesting, etc. So, but the actual summary care data doesn't reside within the EPR, and it's read only. I think this is one of the fundamental things that we have around interoperability versus integration. Integration is generally a read-only view. You can't go back to the source system, annotate it, update it, or collaborate with colleagues as you sort of step through these. And we have this big challenge across the NHS where we have distributed copies everywhere. And when you start talking about other sorts of parts of the health record, like say an end-of-life care plan, you shouldn't have multiple copies because you've got really important information on there. You want to make sure you've got the most contemporaneous version of that. So for us in the genomic space, because we're still predominantly paper-based, we want to come back and try and sort of address some of these fundamental data sharing challenges. So the answer really is to move ideally to an interoperability pattern. So interoperability isn't just about sharing the data, it's also about sharing functionality. And it's touched upon a little bit in the last presentation when you start bringing in clinical precision support and other sorts of capabilities. If you want to utilize capabilities of external systems, you need to have API-based interoperability where the systems can have not just a sharing of data conversation, but passing data back and forth, having different functionality performed upon that. So, for example, if you think about an EPR like Epic, where you've got, say, an external clinical precision support system, so using the CDS hooks things that was just briefly mentioned, I'll cover a little bit further in a bit. You'll want to pass enough information about the clinical record, and it's not just the pharmacogenomic result. There's other clinical data that you need to pass into a clinical precision support system. So your systems, as you pass them back and forth, need to be, once again, having a much sort of richer conversation as you sort of pass those across. And you also, have the appropriate things like access controls, detailed audit. So you can basically enforce different sorts of layers of security and other elements around that when you want to share that data. The challenge that we have in this sort of scenario is that if you wanted to connect multiple systems, multiple other systems, you start having a mathematical problem. So if you want to connect 8 systems together, peer to peer, they're all interoperable, they all share the standard, etc. You need 25 connections. So you need to implement 25 connections, you need to maintain 25 connections, everyone needs to be on the same version, talking the same language. And as you go up in scale, that starts becoming a big issue. So 50 systems requires over 1,200 connections. So what you try and do, if you want to get to an interoperable state, is that you want to try and get into a more sort of hub and spoke type model. So the way that architects try and eliminate that scaling complexity is that we decouple the data. We take the data from the EHR itself, and we make sure that we've got those rich APIs that we can expose and communicate with, but we decouple it so that if you've got 50 systems that you want to connect, you've got 50 connections, not 1,225 connections. So the actual patterns and how you sort of get to deploy this across a much larger economy, especially with pharmacogenomics, where we've got to be linked into practically everything, we've got to have a pattern that is suitable, that we can deploy at scale and at volume. And once again, interoperability, the standards, et cetera, is fundamental of this. And then what happens is if you add another system, you just plug it into your core hub again. So you're not impacting all those other parts of the system. So if you've got part of the record, a pharmacogenomic profile that's sitting in one EPR, another assay, maybe a patient's data with pharmacogenomics can live over a fairly long period. They might have another profile that's done in another part of the country because they've moved. You've got to have everything wired up, otherwise you don't have a holistic picture of a patient's pharmacogenomic profile. So once again, trying to centralize this in some way, shape, or form is an advantage. So it's also easier to secure and control access to the data. You can enforce common standards, which is a real key one, because HL7 2.x is a really good example of this. There's a saying in integration circles, which is if you've seen one HL7 message, you've seen one HL7 message. There is no standard with HL7. It's more of a bit of a framework. Every implementation of it is different. I've been doing this since 2006, and I've never had an easy integration interface. It's never been just plumb it in and work. There's always some sort of nuance that you have to deal with, be it from the LIMS side, be it from the EHR side, or other circumstances that you have to deal with. So this particular pattern is quite different because it allows us to reuse the data in different contexts, which I'll touch upon in a little bit. But NHS England's genomic unit, we want to decouple that record and store the pharmacogenomic profile in there so we can reuse it across the system. And that's the unified genomic record that people may have heard about. We commenced some of the design and discovery work around the UGR about February last year, and we haven't sort of broken soil yet. We've not built anything. We've not gone and actually established any of this. We've got some prototypes and whatnot, but we're still very much in that consultation engagement phase. I think how we want this to work for pharmacogenomics, that engagement back with NHS England is really important as well. So the UGR itself is a mix of a lot of different technologies. So it can be a little bit difficult to kind of conceptualize, but the best way to think about it is a bit like a virtual case node. So we have a single folder, a root folder at the top, which is the NHS number. So you have a UGR per patient. So it's really important that you have one of these per patient context. UGRs themselves can all sit within the same infrastructure and the same database, et cetera, but the way you interact with it is always in a single patient context. Then you can have a section of subfolders inside that have value to different stakeholders. So we've mentioned before about sort of PDF results, for example. At NHS England, we're being fairly pragmatic. We're going for PDF results initially, but we're working on structured reporting currently. So when the UGR is up and running, we'd have structured reporting as well. But the information that's of value to clinical scientists and bioinformaticians is different and should only be exposed to those in that context. So the whole idea is that the UGR is trying to create those different sort of components within that so that you can share those as appropriately. And from a pharmacogenomics perspective, we anticipate that we will have a virtual folder, if you like, which is a patient's pharmacogenomic profile. And no matter where their pharmacogenomic assay is done or point of care testing is done, the result of that would be written into their profile in the UGR and then available to anyone that's interoperable sitting on top of that. So we're decoupling people from hospitals, from geographies. And once again, for the longevity of this, it's fairly sort of important to have that pattern. Also, I've got here things like, actually, I don't have it on this slide, but things around things like family sharing. So the ability Sometimes it's a little bit less so in pharmacogenomics, but the ability when you've got fetal records and things like that. So being able to link family, to the mother's record, or when you have things like organ donors, etc. So the whole idea around the UGR itself is you can have consented, controlled, fully auditable, patient-controlled ways of linking records where appropriate. But it's not something that is necessarily applicable to pharmacogenomics specifically. The other element below the UGR itself is that, once again, I'm kind of explaining this as a set of folders, but technology and everything underneath it is not one big database where we're putting everything in. So you can have a hybrid mix of hosted data or federated data. So for example, we can keep the pharmacogenomic assay result within the lab and have it exposed via the UGR. So you come in via a single point to access that. If you're a GP that's prescribing down in Southampton, you don't need to know or care that the actual PGX result is sitting in Manchester, for example. It just works because you're adopting the standards and you've got a single point of being able to access this. So we're trying to design this once again for the future, really, more than today. So we're very conscious that the interoperability standards and the FHIR, etc., are still not adopted to the level that we'd want. So the UGR itself is not a single system, and you access it via native systems. We're not going to build yet another bit of software that a clinician has to go connect to. The whole point of this is to try and create something that is interoperable so that people can connect to it within EMIS, within EPIC, etc. Any sort of EHR, chemotherapy prescribing systems, etc. The concept is that if we implement the interoperable standards appropriately and gain access through that single portal, so the NHS England APIM, and apologies, a little bit technical, is the single national front door, how you access all the national services. So no matter where you are in the country for whatever service, you would go into that single front door. If you've got the NHS number, you can find the patient. They've got a UGR record. So it's really simple for system suppliers and providers to be able to come and find and access that record itself. So it acts as that single front door, which is the unified bit in the unified genomic record. We're unifying access through a single point of access, and we're unifying the data and revolving that around the patient. So once again, an EPR in London should care that the report is served from Birmingham, etc. So the other element within this is when you start getting down into some of the sort of lower level read data, etc., is that because genomic data can be quite large, especially when we talk about things like whole genome sequences, we're implementing all the GA4GH standards so that you can use things like HTS-GET and RDS servers, where if you just need to go in and get a targeted set of reads that are within the UGR, you can query that at a high level. So you don't need to get a copy of the CRAM or BAM file if you're wanting to pass the whole genome sequence. So this is really, for me, I'm sort of going to get a little bit out of my depth, but that ability to use whole genome sequencing in pharmacogenomics and how the UGR can potentially allow access to do different things that are areas that we can explore from a digital perspective. But once again, it's not just for pharmacogenomics. So within the UGR discovery, we currently have got a prototype that Genomics England have helped build, where we are extracting star alleles from WGS and then using HTS to share that. And that's something that we've demoed a couple of times. So just briefly onto Progress RX. So Progress RX itself, the concept here is where you're using that external clinical decision support that is hosted natively within the systems. So the likes of FDB with the Optimize RX, with Optum with Script Switch. We've also done a proof of concept in Manchester with Epic. So we have Epic calling out CDS hooks with the service and coming back as well for MTR and R1. But basically what we've been doing is part of the study is that we recruit the patients, and then obviously we perform the assay. We currently store that result within Progress RX, which is less than ideal. It's not a scalable solution. We don't want to have that sitting within a single software environment. The idea is that profile would exist external to that, hosted within the likes of the UGR. But we did this for the study because we've got a low volume of patients, and we want to keep things relatively sort of simple. And what happens is that when the patient presents currently we have this working with EMIS and FDB, Optimize RX. So when a patient presents within the GP practice, the clinical guidance, which is configured centrally within Progress RX by John and the team, is then presented to the practitioner when they do the prescribing event. There's multiple different hooks, and when you can call this out, what CDS hooks is. So it could be on a prescribing event. You could potentially do this within medicine review, etc. But the point of it is that all the guidance, etc., is centralized. So the concern before around like multiple sites having to configure all their own rules, you've now got that, that's very difficult to govern. So the idea of centralizing your rules and configuration centrally, and then exposing that by an external national clinical decision support hook is the pattern that we've gone for. The other element is that once we've done this with one supplier, it's a lot easier to roll it out. So for example, we've got this working with FDB and EMIS. That means any site that's FDB and EMIS country, technically we're ready to go and deploy that, even though we've only done it for a handful of sites so far as far as this trial. We're also working very closely with TPP, System 1, who also use FDB as their back-end technology, and we'll be hopefully having that sort of wired up in the next month or so, and that will be another option for us as well. And the likes of First Data Bank are also deployed in multiple sort of EHRs around the country as well. So the difference here, we're taking it to the next phase, is once again, as we take that profile from the Progress RX, and we store that in the UGR. So now we have a decoupled system. I'm decoupling the data. If we go back to the hub and spoke model about having to connect everyone to everything, we've got to take that profile out, separate that out. But it also means that the Progress RX service itself is agnostic to where that record resides. It can be anywhere in the system. It can be basically the assays can be performed anywhere. Once again, it can come from point of care testing, etc. But the interoperability pattern still works, which means it works at scale for us. And you don't have to connect all the systems together. You don't have to have the peer-to-peer connectivity. The unified front door is still that APIM. So in the proof of concept of this working, that all works in milliseconds. Yep. So as long as you've got no network issues, this is a millisecond level transaction. It's not, someone in a practitioner waiting for ages for something to display within the system. It all has got to be very quick, seamless integration and minimizing that cognitive burden on practitioners when they're prescribing. So finally, I just want to talk briefly around data reuse. So pharmacogenomics is obviously a bit of my passion because of the work I've been doing with John and Bill and the team in the Northwest. However, the UGR is designed for the advancing and accelerating of genomic medicine in general. And the concept around this is that we wanted to make sure that we're able to reuse the data. And these are the 4 lenses that we're focusing on, because a lot of traditional approaches, you generally find it's a siloed approach. So if you're doing something in population health, it's a whole lot of population health management systems around the place that you've got to get the data into. You're doing direct care, it's a whole lot of direct care systems that you're putting data into. And research is a nightmare in its own right. Anyone who's tried to get access to research data, I don't need to basically expand upon that. So trying to make it available to different people, but with all the proper controls and consents and mechanisms wrapped around that, the UGR is a fundamental enabler, because we don't want to sit there and just have a solution that only works in a vertical. The idea is that we want to make sure that we're able to support these different environments. And then it's use case driven. So this is not putting it all in and turning the taps on and everyone can go and access the data and do whatever they want with it. We still basically have to govern this appropriately. We have to be engaged through our different patient groups. The ability to be able to expose the interaction and who's using the data and why is really, really fundamental, which is once again one of the reasons the UGR is in patient context. So that we can basically, if someone turned around and said, we don't want to share any of the data, I only want it for my own purposes, in theory, as far as the technology is concerned, we can lock that down and no one will be able to have access to that data. I think from a confidence trust perspective, you've got to be able to have that capability, because if you're throwing all the data across the system, you're not getting that back. If you've got a distributed around system, it's just technically not feasible. So it makes it much harder to comply with GDPR in the first place. So really, I can go into much further around these different scenarios at another time, and I'm happy to come back and sort of do another presentation. But what we're trying to do with interoperability is sort of remove these digital barriers. So it's implementing the standards, but also implementing the patterns. Standards aren't alone enough. If everyone adopted, I could wave a magic wand and everyone supported all the UK core fire standards, or supported all the fire stuff properly, or even the HL7 2.x, we still have problems with the way that the NHS is structured. Yeah. We've got lots and lots of different entities, lots and lots of different providers. We've got 42 ICSs, we've got thousands of GP practices. The patterns that we implement on top of those standards is really, really key. And hopefully today I'll just shed a little bit around how pharmacogenomics can be accelerated if we implement those patterns. We've got an opportunity to do that because we're sort of a little bit green/brownfield at the moment. Thank you.
the regulatory framework when you get it into practice?
So when you mean, so when you say categorize that,
Well, EU, IVDR, or with a UKCA.
yeah. So the thing around, so from Progress RX is concerned, basically we have to engage with MHRA and go through all those processes. So I think as a medical device, it's quite difficult where you delineate where the decisions are being made. So we would be, for example, when Progress RX communicates that information back and forth, we're sending back we receive the gene and the DMD code for the medicine that's being prescribed. We then take the star alleles from the patient's record and map that currently to a modified version of the CPIC guidance, and we provide the guidance back. And that, in theory, you could just put the star alleles directly into a GP system, and the GP could go find what that guidance means and get that phenotype, etc. So you're not making like a decision tree kind of logic. It's not an algorithm. But when you're putting that data back into a clinical decision support system, you are. So for us, we believe we fall on the side that my colleague here was talking about medical device. Most software today, if you're making anything that is a fork in a road for a practitioner to go left or right, is a medical device. And I think in the NHS, we're transitioning to that. You know, I've been sort of on the coalface for a while, and yeah, the clinical safety, medical device, information governance is much more focused on now, quite rightly, than it was, say, a decade ago.
You had a question.
Yes, thank you. Yes, good morning. I'm Maria Hobega. I'm a medical officer at MHRA. Thanks for your interesting presentation. I just would like to visualize how, the relevance of all of this in practice. So, for example, giving a specific example, patients who suffer, who have got DPIT or heterozygous and have got certain variants, and in oncology setting, which would be in secondary care, they would present to their oncologists and they would carry out the testing. So presumably the results would be in one of those hubs or one of those accredited laboratories. That would be communicated to the secondary care, and based on that, the oncologist would be prescribing the 5-fluorouracil related oncological product. And there have been events, we have received information from patients and relatives that, some of these events have been missed. So I just would like to know how your system would be able to help. I know that you talk quite a bit about primary care, but what is the role of, in practice about this, and how does it help sort of bring all the information together for all healthcare professionals? Thank you.
Yeah, no, it's a really good question. I think just for a little bit for context, I was Chief Information Officer at the Christie for 4 years, so tertiary oncology centre, and sort of relatively familiar with sort of medical oncology, chemotherapy prescribing systems. Nowhere near as my colleague at the back there who's smiling at me at the moment. However, the concept that the way the DPYD and those sort of results are currently shared are generally sort of electronic or via email, and then it's manual transcription into the system, and it might be into the EHR, and then it's shown as an allergy into the chemotherapy prescribing system. So what we're trying to do is to say this sort of remove the steps, the hopping points from that where things can go wrong and the connections that you require. So if you've got that DPYD result and there's one single unified place to go and get that, the chemotherapy prescribing system for that patient can query that and get that information back. So it's trying to basically, once again, as far as the title is concerned, we're trying to get to an interoperable environment where those systems are able to get that directly from the source. And yeah, the current methods at the moment are very dependent on the local institution, their local systems and processes. But I know a lot of it is still predominantly manual based with manual data entry currently for that sort of thing, which is prone to errors.
Okay, great. Thanks very much, Scott.
Thank you.
We lost about 10 minutes because of technical problems. We are late for coffee. I think they're waiting out there. So can I ask you to come back in 10 minutes, please, if that's okay, instead of 15? 10 minutes, please.
Yeah.
I literally just got mine.
And I just sent you a couple of slides. I know. I think I'll just pop in the chat.
I think with the nice guy, was available for other things. It was really but I'm saying, yeah, I don't do this fucking thing. Really.
The complexity of it is mine.
That's the way.
Yeah.
I come from second basically halfway services. Like from a national perspective.
Well, exactly. I mean, it's interesting as well, the generations you see swatch out more genome data that could be integrated into the framework that you're sort of making it. Because we have a basic.
So once again, the way there are opportunities for this. I don't think we've got to get because they're start somewhere, show value, but it's like we're seeing it within the program. It's not seeing it. Yeah. Whatever you find.
Not one of and
there's a margin there. Radiology stocks.
Yeah.
Okay, radiology basically stopped doing things, but it wasn't the return investment. So, but I think the challenge that you have to work on the meeting projects, all that, start there, getting on with agencies with original points, and they the thing is like people that are solutions. There are decisions that we have been really to focus on. There's things that are in the mind start, and we haven't got an estimate of that if they seriously that's what changes. I find it.
It'll be interesting that sort of we have like patients the reason I said, did we gel some of your data and then practically how the patient perception of genomics is used in that it's explained well in the generations.
1, 2.
It can be, you can switch somebody from telephone to one.
Solution. It's then takes
Clinicians as well. I mean, TP1 is right. I mean, it's not that it has to be a methodology. It's not being. It's not they didn't look. So it's only the challenge. So cheap. I mean, the benefits in EHRs I heard of personal health in myself. And somehow we've only ever, So when's the testing? So I've heard it now about now. It's another yes. Yeah. 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 Oh, like, so you're talking to G-Prime about that?
Yes.
There are only one textbook, so I'm really well. Oh, that's really good. Because we know that my solution is very much a preemptive test. It's not really side of that. They presented about how they'd gone through the ethics review, so they communicated with patients, so they're reporting their works on HRA 0 in April. And it's really interesting how oh, I mean, once you've got you take what with it? Yeah. You see, it's a shame they didn't get funding to do this. They got the buckets. They have the data, but they haven't funded. And I think it's probably something we have it. Or but markets are definitely on there, and then HRA looked at well. Did you study this yet? Which? Well, there's been one in it's not, and it's not very disease, it's very difficult, you don't need scientists to why not? And it would incorporate into
You give this friend it's not sticking down to fine.
Yeah.
Okay, can we so get restarted, please? Let's get restarted, please. Okay, next talk. Let's get restarted, please. Okay, the next talk is from Cinzia Dello Russo. And Cinzia has been working from the beginning on this particular network. So Cinzia is going to tell you exactly what the last 4 workshops covered. So Cinzia, please.
So, good morning, everybody. As you probably know, because most of you have been in our workshops, we run 4 different workshops trying to understand during this discovery phase and try to map what is the complex regulatory system for pharmacogenomics. And I tried to put everything in one slide from what we learned from different speakers. I might forgot something, I don't know, but there is a okay. So there is the drug with the genomic biomarkers, the genetic test devices, genetic testing, and then all this information needs to go somehow in the NHS. And you heard today several times that the most used format at the moment is a PDF, but we want to incorporate this information in the electronic record of the patient and probably link this to the clinical decision support system. And in order for this to work, then we need also pharmacogenomic prescribing guidelines. And these are all the regulatory frameworks that brings, I don't know, a drug on the market or health technology assessment for genetic tests as well as drugs. And all the standards that need to comply for industry, commercial laboratory, And then you heard today from Joseph about the medical device regulation, which are different from the Great Britain and Northern Ireland. So it's fairly complex and ecosystem. And what we would like to know with this network is to find a way to streamline this process. So the first workshop was mainly based on pharmacogenetic annotation in drug labels and prescribing guidelines. We went over two use cases of implementation, DPYD and fluoropyrimidines and CYP2C19 genotyping for clopidogrel in stroke. And we went over all the regulatory issues related to these two cases. We briefly touched over health economics and pharmacogenomics, but then we had a final, a fourth workshop specific on this topic. So as you can see from here, there were many points that were discussed in this first workshop. I will not go over all of this, but just one topic was the pharmacogenetic annotation in drug labels, and this particularly is a problem for the old drugs. And there was some sort of consensus about the need to systematize this pharmacogenomic information in drug labels. For example, we know that if there is a safety issue, we can update the SPC. But this needs also engagement with the market authorization holder, and this might be a lengthy process. Therefore, we might need to find a way to implement pharmacogenomics, despite the labels might be a little bit not aligned with the new evidence. And then there were also other discrepancies that we discussed within the label. So just to see some data, for example, this is an initial work that we have done during these 4 months, is comparing the MHRA drug label with the FDA drug label. You know that the FDA has a table with the pharmacogenomic biomarkers. The CYP2D6 is the most frequently annotated gene. And I know it's very small, but you can see that for these 12 drugs that have a CYP2D6 annotation in this relevant section of the label, indication and usage, and dosage and administration, there are several drugs with a specific dose recommendation in their label in the FDA, but then there are only 2 that perfectly align with the FDA label. So we really need to update this, or there was also some sort of consensus about keeping the label as a basal level of information and relying on guidance. So from this first workshop, the need of UK-specific pharmacogenomic prescribing guidelines emerged really clear. There are international guidelines. These are not fully aligned. So there was consensus of this need to have some sort of UK pharmacogenomic prescribing guidelines, including particularly the eligibility criteria for patients that need to be tested and possibly some sort of economic evaluation. A potential nice recognition of these guidelines as well. And then we went over a lot of different topics for industry, new drugs, and pharmacogenomic, and research can support the industry in development of new drugs, avoiding the issue that we saw with the older drugs. Then we have a second workshop on embedding pharmacogenomic in the electronic health records to inform clinical prescription, and we talked mostly about standards, guidance, clinical decision support system, electronic health record in the NHS, mainly focusing on primary care, and today we completed with the EPIC talk on secondary care. And we had also an update on the progress study, which you heard about from Scott, and particularly on the regulatory issues related to this trial. This is an implementation trial. As you can see from this workshop, there were several important points that were made. Again, considering the relevant heterogeneity among current guidelines, also in this workshop emerged the need to have PGX prescribing guidelines specific for the UK, with the periodical updates specific in a specific repository. These guidelines may be used to build a clinical decision support system, can be used when the SPC is not fully aligned with the new evidence. And then there were also other interesting topics, like, for example, using other genotyping programs. So this is something that we heard, like derive pharmacogenetic information from other programs, genotyping programs, standardization of genomic data, digital infrastructure. We briefly go over the unified genomic record, and we had a talk today more in depth in this topic. And then we talked about intelligent clinical decisions support system, kind of alerts that we need to provide, kind of recommendations. And there are, for example, two ways, even to mandate a change to the prescription or to refer to the guidelines. And then there was some consensus also on the need to education for healthcare professional and patient in this specific workshop. Workshop 3 was mainly on pharmacogenetic testing, developing and providing pharmacogenetic testing in the NHS. Sorry. Basically, we thought we had a first presentation by Joseph on the regulation of medical device, in particular in vitro diagnostic device. We had also the nice point of view on health technology assessment of tests, and we focus also on genetic testing, particularly focusing on industry providing this pharmacogenetic testing. And here we learned that there are different requirements for the approval of in vitro diagnostic test. There is, for example, this health institution exemption rule for tests developed in a trust and used in that trust. We noticed that there are many regulators to get a test into the system and into the NHS, and therefore from this workshop it emerged clearly the need to develop a streamlined regulatory pathway for pharmacogenetic testing development and implementation in the NHS. For example, it would be useful to have all these documents in one single portal and having a clear guidance on what the manufacturer needs to do and what assessment they have gone through in order to avoid duplication. And there was also some consensus on guidance for industry applying to MHRA and NICE on what is necessary for the approval implementation of their test and clinical decision support. Finally, we had a final workshop on health economics evaluation for pharmacogenomics, and this was very informative because we went over the different health economic models for evaluation of cost effectiveness. The current approach for pharmacogenetic testing, we had again the feedback from NICE and two workout group talking about the value of a single gene test versus the panel, the comparison of evidential standards versus other biomarker tests. And here is the main points from this workshop. So cost utility analysis is the main method used by the NICE HTA, but most likely a cost utility analysis may not capture all the benefit of PGX testing. So probably we need to develop a proportionate economic model, especially to evaluate these gene panel tests, including other important values of these genetic tests, like incidental findings, personal utility, avoiding inequality. Then we learned that there are several ways to evaluate or commission a PGX text in the NHS. We learned 4 different routes in Wales, but there are also, I think, in Northern Ireland and in Scotland, different ways. So we might need to centralize these. Probably budget impact analysis will be necessary for the full implementation of pharmacogenomics in the NHS. And again, it emerged that we need to educate regulators, healthcare professional, patient, and also industry. So for all this work, and this workshop were really well received, and we had a lot of participants, 45 people on average per each workshop. Important feedback. What we think we might do in the next phase is to work at the prescribing guidelines, to work at the regulatory pathways for implementation of a genetic device, genomic testing, as well as a clinical decision support system, to work at the education and training for regulators, healthcare professional, industry and patient, and also to get the patient and public involvement and engagement. And these are the topic of the 4 breakout group that we planned for this workshop. Oh, sorry then. So this is just a suggestion based on your expertise, whether you want to join these different groups. Feel free to move in different rooms if you don't feel that this is the perfect location. So we will have a first group on guidelines in the alley room, which is across the hall, that will be chaired by Prof. Pir Mohamed. Then we will have a second breakout group on regulatory pathways for PGX IVD. Stay here. This is industry-based and is chaired by Jackie O'Brien. Then we will have an education and training, a group on education and training, which is chaired by Emma Magavern and Maria Takiroglu. Sorry if I pronounce not correctly. And this is going to be in the Grosvenor room, which is again across the hall. And then we will have a group on patient and public involvement and engagement. That is the room in the back, park room, which is chaired by John.